Hello and welcome everyone. Today we'll be discussing about thrombocytopenia in sepsis. Thrombocytopenia, that is low platelet, is very common in the ICUs. It occurs in approximately 25 to 55% of the ICU admissions and up to 50% of the patients who are admitted to ICU after surgery. The common causes in ICU are DIC, which is most frequent, that is disseminated intravascular coagulation, followed by thrombotic microangiopathy. This includes conditions such as TTP, thrombocytopenic purpura, hemolytic uremic syndrome. Frequency in sepsis is ranging from 37% to 83%, which is a very high prevalence. Sepsis-associated DIC specifically accounts for nearly 10 to 20% of the thrombocytopenia cases. Key findings from published studies have shown that we have very limited study specifically distinguishing the TMA from DIC. Among the published research, 5 studies linked thrombocytopenia primarily to DIC. Only one study explicitly reported the TMA. One study reported both the DIC and TMA simultaneously. Research often uses data from only 1 or 2 centers, limiting wider applicability. So DIC is the first condition that we are going to discuss. What is the pathophysiology? DIC involves widespread clotting within the blood vessels throughout the body. Now, excessive activation of the coagulation system creates numerous tiny clots, that is microthrombi. These clots block the blood vessels, causing reduced blood supply, ischemia, and potential organ failures. The platelets and the clotting factors are rapidly used up in forming these small clots, leaving insufficient amounts to manage new bleedings, resulting in severe hemorrhages at various other body sites. So there are 2 subtypes to DIC. The first is fibrinolytic phenotype, that is hypofibrinolytic, the commonly seen after severe trauma and in blood cancers, where excessive breakdown of the clots causes severe bleeding. Analogy is like using too much drain cleaner, causing the pipe damage and leaks, excessive clot breaking down, leading to bleedings. So hypofibrinolytic, in this most commonly associated is the sepsis 1. The inflammation triggers the plasminogen activator inhibitor 1, which prevents normal breakdown of the clots, worsening the ischemia. So in sepsis you find more small clots which are blocking and causing ischemia. So analogy is like a blocked drain that aren't cleared, causing backups and worsening damage. So the clot remains stuck, causing organ damage. So role of immunothrombosis in DIC. Immunothrombosis is the body's defense mechanism to contain the infection by forming small clots around the pathogen. So this is the reason why we have those small clots. It becomes pathological in DIC, which is the why there is excessive clot formation. The WBCs release the nets composed of DNA and histones, and these are used to trap the pathogens in these nets. These nets and histones, they stimulate more coagulation and inflammation and reduce the clot breakdown, contributing significantly to the DIC. Now, platelets become activated through specific receptors. These are the various receptors, as you can see, further promoting the clot formation. So the whole idea of this is initially to contain the bacteria or the infective organism. However, if it becomes too widespread, it results in more consumption of the coagulation factors and risk of bleeding, as well as these clots become too much in amount, causing ischemia to the target organs also. Now, how do we diagnose DIC? This is not very easy, and there is no single test, and we really don't have any gold standards. Diagnosis essentially relies on various types of scoring systems where we combine clinical signs and lab markers for the coagulation. Common scoring system that we use is the most common one, that is the international, that is ISTH. You have the Japanese one, which is the JAAM. It is more sensitive and identifies early DIC. The next is the Japanese Ministry of Health Welfare, which is sort of a basis for the ISTH. So most of the studies are coming from Japan, and most of these societies. So ISTH is something which is globally accepted, while JAM is something which is more frequently used in Japan. Early diagnosis through scoring system helps identify patients needing treatment, potentially reducing mortality. Now, the treatment of DIC, the standard treatment focuses on managing the underlying condition. You can't do anything to reduce the inflammation. So you try to control the source, that is, control the infection, give supportive care so that the infection reduces, the inflammation reduces. You can give platelets and FFP to replenish the clotting factors which have been used up, anticoagulation therapy to stop further clotting. Early studies have not really supported a survival benefit of using anticoagulation in all septic patients, leading to limited use in Western countries. However, recent studies have clarified that anticoagulation can benefit patients specifically identified as having sepsis with DIC. The Japanese guidelines now recommend antithrombin and the RHTM therapy, that is recombinant human thrombomodulin, in selected cases. In important clinical tip, the patient selection here is critical. Anticoagulation has shown benefit primarily in severe DIC, not in mild coagulation abnormalities. So you need to understand the patient selection, the drug usage and its complication, and then try to find your correct population. Next is thrombotic microangiopathy. What exactly is this? It is a group of disorders which is mainly characterized by three main clinical features. The first is obviously thrombocytopenia. The next is MAHA, that is microangiopathic hemolytic anemia. That is, the RBCs are getting destroyed in the small blood vessels. And finally, because of these small blood vessels getting affected, you have end organ damage. So how this TMA happens? What is the pathophysiology? The damage occurs to small blood vessels, that is the arterioles and the capillaries. The abnormal blood clots form in these vessels, blocking the blood flow. Now, unlike DIC, severe clotting factor depletion and widespread coagulation test abnormalities are not typically seen over here. So you don't really see any clotting factor abnormalities. Now, typical lab findings are low hemoglobin, haptoglobulin levels, high retic count, lactate dehydrogenase and bilirubin because of the RBC breakdown, presence of cystocytes with a fragmented RBC in peripheral smear is very, very important here. Normal or mildly prolonged coagulation tests, unlike DIC where it is significantly affected. There are various types, as we have already discussed. It is thrombocytopenic hemolytic uremic syndrome, mainly because of the SIGA toxin, and next you have the complement mediated HUS, and finally you have secondary TMA, that is, it is a microangiopathy which is secondary to a drug, pregnancy or even a cancer. So coming first to thrombotic thrombocytopenic, the causes are the deficiency of the ADAMTS13 enzyme. This is the enzyme which is responsible for breaking down large multimers of von Willebrand fractures into small fragments. This prevents excessive clotting. Now what happens is, when there is a deficiency to this, which can be congenital or it can be acquired because of autoimmune antibodies targeting this particular enzyme, then the patient may present with the clinical pentad, which is, as we have already discussed, thrombocytopenia and MAHA. Apart from this, in TTP you will find, which is very important, neurological symptoms, fever as well as renal dysfunction. Neurological presentation is very, very critical to identify and diagnose TTP. The practical diagnosis is suspect TTP in patients with unexplained low platelets and anemia with cystocytes, especially if you find neurological signs. Next is diagnosis. How to diagnose is to actually measure the ADAMTS13 activity, which will be less than 10%. Obviously, this is not something which is commonly done and it will be readily available. So if it is not done in your center, or it is obviously going to take some time and you need to do something, so then you have what is called as the plasmic score, which help in quickly estimating the likelihood of TTP. The treatment lies in plasma exchange, which removes the harmful antibodies, replacing the missing enzymes. Steroids and rituximab can be given. Finally, we have calpacizumab, which blocks the platelet von Willebrand factor interaction rapidly and prevents the coagulation and all. Recombinant ADAMTS13, it has been recently approved for congenital TTPs. The next we have the hemolytic uremic syndrome secondary to the Shiga toxin. The cause here is the infection by the Shiga toxin causing E. coli, which is a strain. The name is given over here. The mechanism is the Shiga toxin directly damages the blood vessel lining, activates the platelets, causing small clots. This is important that it is mainly happening in the kidney. So in this case, the clinical presentation will primarily be in younger age group, that is children less than 5 years, but adults can also get affected. So it will start with some kind of a diarrhea, abdominal pain, vomiting, and finally after 2 to 12 days you can possibly have kidney injury. The neurological symptoms are rare, but they can do happen. But then the important thing that you need to know here is the history of a diarrhea or abdominal pain, vomiting, mainly GI symptoms. Regarding the diagnosis, the culture and the rectal swab testing for the E. coli 0157H7, uh, stool culture is negative if tested late, so blood antibody testing can help in these cases. Treatment here is supportive. You give fluids. If the kidney is bad, you need to do dialysis. Antibiotics are avoided because they don't really help much, and plasma exchange has no clear role used if difficult to differentiate from TTP with this particular syndrome. The thing is, it can have overlapping symptoms with TTP. So if becomes too complicated, maybe you can go for plasma exchange also. Finally, you have the complement mediated hemolytic uremic syndrome. The causes are genetic, acquired abnormality causing uncontrolled activation of the complement system, damaging the blood vessels. The mechanism is excessive complement activation causing the blood vessel damage and the microclots. The presentation is you don't really have a diarrhea, but then diarrhea can occur. It's not really mandatory that you should have diarrhea here. Kidney failure is common. Neurological symptoms are frequent and often triggered by infection, pregnancy, and inflammatory conditions. So diagnosis again is pretty complicated. Genetic testing for complement mutation and autoantibodies can help. Clinically, suspicion can be done, but as you can see here, a lot of overlapping symptoms, really very difficult to pinpoint. Treatment is essentially the antibodies that directly inhibit complement activation. These have been recently used and they have been quite effective. And plasma exchange obviously will help here, but then obviously you can start it while waiting for a specific diagnosis. Dialysis obviously if the renal function worsens. Secondary TMA, the causes are drugs like quinine, cyclosporin, tacrolimus, various chemotherapeutic agents. Pregnancy related, as in HELLP syndrome, preeclampsia, cancer like gastric and breast cancer. In this, the drug-induced TMA usually stops after discontinuing the causative drug. In pregnancy, TTP and complement-mediated HUS should be considered if the patient doesn't improve quickly after delivery. In cancer-induced TMA, commonly associated with metastatic gastric and breast cancers, chemotherapeutic agents can also trigger the TMA. Treatment involves discontinuing the offending chemotherapeutic agent, supportive care, and blood pressure control. So now that we have discussed the two major causes of thrombocytopenia and sepsis, we next focus on the other important causes. The next important is HLH, which is very, very important again. The definition is severe inflammatory syndrome characterized by excessive activation of the macrophages and T cells, which cause widespread tissue injury. Now, the mechanism is that it's a defective immune cells cause uncontrolled inflammation, leading to a massive cytokine storm kind of a thing. Now, this results in destruction of the blood cells, including the platelets, and obviously there is multi-organ damage. The diagnostic criteria that we use is the HLH 2004, where you have fever, enlarged spleen, low blood counts, high triglyceride, low fibrinogen, presence of hemophagocytes, and this is in bone marrow, low activity of natural killer cells, very high ferritin levels, high soluble interleukin 2 receptors levels, and based on this you can make the diagnosis of HLH. The triggers are infection, especially viral like this Epstein-Barr, but also bacterial can cause. Rarely lymphomas like intravascular lymphoma, a type of lymphoma that mimics sepsis. which is present differently in Asian versus the Western population. That must be kept in mind. Regarding the clinical aspect, suspect HLH in ICU patients not improving despite appropriate antibiotics, and early identification treatment of HLH can significantly improve patient outcomes. So sepsis can directly cause platelet count decrease because of the infection, but then it must show response within first 3 to 4 days. If it is not showing, then please start suspecting HLH here. The next cause could be COVID-19 associated coagulopathy, but then you need coagulopathy, COVID-19 here. It's a coagulopathy related to the SARS-CoV-2 infection, leading to clotting risk and platelet dysfunction. The severe inflammation and viral infection activates the platelets excessively, yet the platelet counts may drop. Unlike traditional DIC, the COVID-19 doesn't typically show severe coagulation abnormalities. That is, you don't really have coagulation problem, like prolonged PTs and low fibrinogens. There is markedly elevated D dimer levels though. Regarding the diagnostic criteria, patient must have at least 2 of these, that is platelet count less than 150, D dimer more than twice the upper limit, and slightly prolonged PT, that is more than 1 second, and INR more than 1.2. Low fibrinogen level, and evidence of thrombosis. In the COVID-19 associated coagulopathy, the treatment is heparin because it will be anticoagulant, anti-inflammatory, and also having some antibacterial, antiviral properties. Early use has improved outcomes. Thrombocytopenia of chronic liver disease, this is one of the other conditions, that is cirrhotic patients. They have multiple reasons for platelet decrease, like splenomegaly, which traps the platelet, reducing circulating count. Portal hypertension, further worsening the splenic sequestration, reduced thrombopoietin production because of the liver dysfunction, viral infection and autoimmune issues suppressing the platelet production. The clinical importance is that thrombocytopenia can worsen the acute and chronic liver failure triggered by infection. Now, liver dysfunction from infection and acute deterioration often mimics and leads to DIC. Clinician often should differentiate between a simple liver-related thrombocytopenia from a true DIC, which is going to be very difficult because liver dysfunction will also affect the coagulation parameters. The next one is the heparin-induced thrombocytopenia. It is a severe immune-mediated reduction in the platelet activation, thrombosis, and thrombocytopenia after a heparin exposure. The heparin binds the platelet factor 4, forming complexes. Now, body produces antibody against platelet factor 4 heparin complex, and antibodies complex activate the platelet and monocyte, causing clots despite low platelet counts. In this, you will find typically presentation 5 to 14 days after starting a heparin, and you will have platelet counts which are dropping rapidly, but bleeding is very rare. You will find a lot of clots, especially in the veins. That is, you will find DVTs, pulmonary embolisms, catheter clots, everything happening. Finally, the diagnosis, you use the 4T score, that is thrombocytopenia priming, thrombosis, exclusion of other causes, estimate the likelihood of it. Treatment is stopping the heparin products, alternative anticoagulation to be used. Special note regarding spontaneous, it is rare condition similar to HIT occurs without prior heparin exposure, especially with severe infections due to autoantibody against the PF4 induced by pathogens. Now, there is a relationship between DIC and TMA because they can overlap and make difficult the diagnosis. The basic concept is that both injure the small blood vessels and form tiny blood clots. The main difference, however, is that DIC primarily involves fibrin clots occurring mainly on the venous side, whereas TMA primarily involves platelet-rich clots mainly occurring the arterial side. This must be kept in the mind. The clinical feature difference, like DIC is commonly present with hypotension, organ failure, respiratory distress, significant bleeding due to depletion of clotting factors. While in TMA, you will have hypertension, commonly acute renal injury, bleeding is uncommon, and organ failure is more common. So this is a table which is summarizing the thing that INR, the coagulation parameters are prolonged in DIC, FDP and DNA again markedly elevated in DIC, fibrinogen often reduced, LDH and bilirubin will be markedly increased in the TMA due to the MAHA. Cystocyte again most present with the TMA. So, diagnostic challenge that we get is about 10% of the DIC also fulfill the criteria of TMA, and many TMA fulfill the DIC criteria because we don't have any gold standard. So, we follow these scoring and the criteria. So, differentiating the two is clinically challenging but crucial because the treatment are different. DIC treatment is anticoagulation and TMA treatment is plasma exchange. So the diagnostic algorithm to differentiate the two main approach exists in medical literature. The approach one is that first look for MHA. If you find hemolysis and cystocytes, if present, assess the coagulation parameters, that is the PT and FTP. Reasoning is prioritize TMA identification considering DIC as a secondary. Approach 2, that is the ISTH approach, is first look for coagulation parameters, then if DIC criteria is not met, then check for MHA. Reasoning is that prioritizing early detection and treatment of DIC due to its higher prevalence. Now, in clinical practice, if the patient is having sepsis related thrombocytopenia, following the second approach, because DIC is more common, is more beneficial. Regarding the coexistence of the two, complement mediated HUS can coexist with septic DIC due to interaction between complement and coagulation pathways. Septic DIC can trigger or worsen underlying the complement mediated HUS. Up to 20% of the complement mediated HUS may fulfill the DIC criteria. Adams 13 and secondary TMA in DIC patients. Adams 13, the enzyme is crucial in preventing abnormal clotting and can be reduced due to severe sepsis and systemic inflammation. Low Adams 13 activity is diagnostic of TTP, but milder reductions can occur in septic DIC as well. Low Adams 13 during sepsis strongly predicts renal failure and worse outcomes. So this algorithm basically shows us how to approach thrombocytopenia in patients with sepsis. So initially, try to find out whether the patient has DIC or not. If the patient has features of DIC, then consider anticoagulation therapy including antithrombin and the recombinant thrombomodulin. If the patient has no DIC, then try to find the TMA. In the meantime, you can also be looking for the MAHA. If TMA is confirmed, then try to find out whether it is TTP or HUS and base your treatment on that. If the patient is not showing any of the features, then you can repeat your scores to see whether the criteria meet later on. Regarding the TMA, if TTP is confirmed, then give the PLEX and the specific inhibitors. For the HUS, that is Shiga toxin related, give supportive care. If nothing is working, then complement mediated, try to use the monoclonal antibodies. And finally, if nothing is working out, then try to find out the other causes that we have discussed, like ITP, HIT, COVID-19 associated HLH and liver failure, etc. So the take home message is thrombocytopenia is common in ICU, especially with sepsis commonly caused by DIC. But always consider other diagnoses like TMA, HLH, COVID-19, coagulopathy, liver disease and HIT. Early simultaneous evaluation of DIC with TMA is very, very important. DIC treatment involves anticoagulation and managing the underlying cause. MHA involves plasma exchange, supportive care, and complement inhibitors. HIT should be suspected with thrombocytopenia and recent heparin exposure, treated by immediately stopping the heparin and alternative medications. Early recognition is important. Correct diagnosis, timely specialist consultation, and appropriate targeted treatment help improving patient outcomes. Thank you for your patience.